Dr. Siddiqui. How are you?
Hey, I'm doing well. Well, it's not morning here. It's
Oh,
actually
sure.
like afternoon, but it's a really nice fall day in Rhode Island. What about you?
I'm in the Northwest, so we don't have that nice of a fall as you do have in New England,
Yeah,
but
it's still like cool there, isn't it cool?
we have a lot of evergreen trees that don't make that fall transition so much. So mostly
Oh,
foliage.
yeah.
We had a couple of the fires for the past
You
few weeks.
guys did too?
So the fires from Eastern Washington and Northern California, the smoke would come up to us. So we had a couple of really hazy days, though it was kind of depressing. But so far things are clearing up.
Yeah,
Thanks for asking.
of course. I know we're OBGYNs and we're all like pro anything moms do to celebrate their pregnancies, but some of these gender reveal parties are getting completely out of control.
Causing fires. They're causing fires just for our audience if they know. One of the fires is started by gender reveal parties. So be careful out there.
Yeah.
Um, it's crazy. People will do whatever.
I know.
Um, So yeah, I guess speaking of this time of year, September was actually the month of PCOS Awareness Month. So really, granted, we're in October right now, but we're really excited to talk about this topic that's really important to both of us. PCOS stands for Polycystic Ovarian Syndrome. Though, Moiri, I'm sure you've come across this multiple times with patients. So just in your own words, tell us a little bit about PCOS.
Sure. So PCOS is mainly it's I don't want to necessarily say it's a hormonal disorder, but basically what it is, to put it in very layman's terms, is just having one certain set of hormones that like overwhelmingly predominate over another certain set. And hormonal changes, especially starting in like the teenage years, are what causes, and throughout the reproductive age, are what causes not just like things with it when it comes to your period, but also like changes in body hair growth and all of these other things, like acne and things like that. So it's not just about like irregular periods. It has like a constellation of other symptoms, but really what it is just it's a hormone imbalance. So I feel that because a lot of times patients don't know that, they kind of end up thinking, okay, what is wrong with my ovary? It's not just like really your ovary. It's like an overall like imbalance of hormones that are causing these issues.
Exactly. It's a syndrome. Hence, it's not like there's not one particular
Yeah, right.
multimodal aspect to the
Exactly. And I think that's why they call it a syndrome and not a disease or a disorder.
condition.
Because there's so many, actually, I do see a lot of PCOS patients who do end up having regular periods, but what they like instead have is like more facial hair growth or like more acne, things like that. But for the most part, the main issue is just the period regulation that ends up being the problem.
And just to backtrack for our viewers, PCOS, we decided to talk about this. It's not a commonly used term. A lot of people might not know about it, and that's kind of the reason why we wanted to talk about it, because it's PCOS Awareness Month. It was actually also highly voted on our poll we took a few months ago, which I'm not surprised by because PCOS is very common among Asians. There was a study I just had looked up that in Europe, it's about the prevalence is about 13%, Australia 11%, Hindu in Asia, which include Bangladesh, India, 28%. And I'm not surprised because I see this condition much higher in my South Asian patients and actually some of my Latin American patients too. And once we talk a little bit about the physiology of it, you'll understand why, because long story short, the answer is diabetes.
Yeah.
So kind of just to help summarize what you mentioned, it's a syndrome. So just having one symptom doesn't mean you have PCOS. It's this collection of symptoms where you should really consider getting worked up. So the mainstay syndrome or symptom is menstrual irregularity, the regular monthly period. I think
Mashik, yeah.
or it's not mashik, it's not monthly, it's irregular. And I think we talked about this in our very first session, where looking at the menstrual cycle is a vital sign. So if you're maybe blood pressure beshi high or beshi low, then you'll go see the doctor. If you're having irregular periods, you should go see the doctor. Like, that's not okay. I think a lot of women just like, oh, I've had irregular menses for a couple of years. No, if you're in your 20s and you've had your period started when you were like 5 years before that, you really should not be having irregular periods. Or historically normal regular periods became irregular, you should definitely go see the doctor. So that's number one. Arekta sort of clinical association is the medical term hirsutism. So basically male pattern hair growth. So chilede jerokom hair growth hoy, so facial hair, chest hair, hair on the thighs. That's, associated with irregular periods. You want to think about PCOS. I don't know about you, Dr. Siddiqui, but a lot of South Asians and Arab patients have facial hair. It's genetic, and that's fine, but you need to get it worked up to make sure it's not hormonal. Arekta, which is kind of captured in the name, is usually these patients on ultrasound have ovaries, so other ovary, then only cyst, so polycystic, and that's also just the ovaries reacting to this hormonal imbalance that Dr. Siddiqui mentioned.
Yeah. And what these cysts are, and it's good to know what the difference is between a cyst and like just a regular mass, because a lot of times these patients can leave the doctor's office thinking that my doctor told me I have a tumor in my ovary, but it's not that like concerning. So it's not a tumor. What a cyst is a very fancy word for like a balloon. So basically what's happening in your ovary is that your ovary actually is really small. Maybe it's like about this big. And then inside of it are these like fluid filled pockets. And like Dr. Hussein said, that they are themselves not creating like extra hormone, but these ball or ballooning of the ovary is a response to it. So that's how we see it on the ultrasound. But I mean, like how many times, Dr. Hussein, do you see patients who have all of the other symptoms of the syndrome, but don't have like these large cysts on their ovaries? It happens too. So it's just one thing that we use to look at to tell you if you have that diagnosis or not. It's really what you tell us that informs us what the diagnosis is.
Exactly. And like those are the three main symptoms. Associated symptoms include obesity, lots of facial acne, which Dr. Siddiqui mentioned, and these patches of blackening or thickening of the skin. So the medical term for that is acanthosis nigricans. But or back of the neck or underarms. Genetically, other population or diabetes in general can cause that, but in the context of irregular cycles, facial hair, the thickening velvety texture of the skin, it's just syndromically suggestive of PCOS. So as your physicians, those are the things we're looking for. Not everyone's going to present like that. Shop symptoms necessarily.
Yeah. And not every patient with PCOS, I mean, has like a wide range of body mass index. Not everyone is, even though we're told that they're more likely to be obese or overweight, it's like not the case for everyone.
Yeah, it's not the case for everyone. It's surprising. So the typical patient with PCOS is overweight. So 80% of the population is overweight, but just actually a couple of weeks ago, I had a patient who has PCOS, BMI of 19. So, yeah. So one of the treatments, which we'll go into later, which is weight loss, that might not necessarily work for someone if you're thin or in the normal BMI range.
And the main reason we end up recommending weight loss, I don't know what you do, Dr. Hussein, but the main reason I end up recommending it is because I know that these patients are at higher risk for diabetes. So like asking them to lose weight, it's really more to help with the diabetes. Asking them to lose weight isn't necessarily going to make their PCOS go away. It's more of just the like consequence of, or because they're at higher risk for diabetes. And then if you have them lose weight, then that risk goes away a little bit.
To add on to that, though, there are recent studies that show that just as little as 5 to 10% weight loss can result in resumption of menstrual cycles.
Oh, so right.
If someone is just, let's say someone hit, hypothetically, 300 pounds, and if they lost, what's 5% of that, like 15 pounds, which isn't very much from the 300, they have resumption of menstrual cycles. So that it does help some. Like you mentioned, definitely the metabolic syndrome, the diabetes, cardiovascular downstream effects, definitely improve. So do you know what causes PCOS? Do we know what that is, or is it just kind of?
Yeah, it's really difficult. I find myself having a hard time, and it ends up being a very unsatisfactory counseling session because I can't tell her exactly like why it happened. I can tell her that for the most part, women who do have it probably have unidentified female like family members who also have it, but have just never come forward. But like the majority of women, like you said, if they really have it, then they start having these signs and symptoms at like early adulthood. Like you shouldn't expect a woman out of nowhere to experience these changes like when they're 48 or 49. Then we're worried about other things. We're actually not really worried about this anymore. But yeah, so it ends up being tough. What I end up saying is that there are like so many different hormones that regulate different parts of the menstrual cycle. And then there's this one hormone, and these are very fancy terms we don't expect you guys to remember, but there's this one hormone called luteinizing hormone that literally makes it so that you end up being in a high estrogen state for a while, and that is what causes all these downstream effects. And it's tough to figure out exactly what causes it, but because we know which hormones are elevated and which hormones are decreased, it helps us figure out at least a treatment plan. I don't know, how do you counsel patients?
Exactly. There's like no cause. Like for example, reactive viral infection, and we know it's from a virus. With PCOS, there's really not one known cause. So we do know of like known hormones, like other problems in it. So more Dr. Siddiqui that you mentioned. So one of the things is the estrogen. So the theory with patients who are obese or in the obese category by BMI, that their PCOS the theory is that the excess body fat actually results in elevations of estrogen. Estrogen does something that our ovary makes. So what's wrong with estrogen? That's not bad. Well, estrogen, when you have too much of it, a small percentage of it gets converted to androgens, which is the male hormone, or testosterone. Our testosterone, you can get the facial hair, the chin, the chest hair, all that stuff. So you can get that downstream effect. Separate pathway is insulin resistance, which is really the underlying pathophysiology of diabetes. So insulin resistance meaning ki to amader insulin amra keno diabetic insulin use kore jokhon tader blood sugar is really high, they use insulin to decrease it, right? So insulin resistance hole, that means the body is not responding to insulin, and so the blood sugars aren't coming down. So people who have insulin resistance have elevated blood sugar, so they're kind of like pseudo-diabetic. You can have some of the acanthosis nigricans, and it's associated with
yeah, it's like this leathery kind of skin that you feel like so it's like Dr. Hussein said, it's not telltale, but oftentimes patients who end up having these symptoms can end up having that too. So it's important to at least see it.
Exactly. And actually, Dr. Siddiqui, I'm sure, deals with this too. The reason why we end up seeing a lot of PCOS patients is their first real symptom is infertility. So that is a big
period problem.
The first bothersome symptom to a lot of our women is infertility. So just to backtrack to the irregular cycles, like what is the irregular cycles? It could be anything. It could be very infrequent cycles or very frequent cycles or intermenstrual bleeding. Typically, I don't know if this is database, but what I see is women, they'll say, oh, I didn't bleed for 3 months. I didn't have a period. And then I had suddenly a heavy period. But that's not normal. And that can lead to infertility. And Dr. Siddiqui, you kind of mentioned this with the luteinizing hormone and ovulation. Do you want to talk a little bit about how infertility plays a role with PCOS?
Yeah, so the luteinizing hormone, what it does in a patient who has regular cycles is that it allows your ovary to release an egg. But what happens in our body is that, I mean, for better or for worse, there's a checks and balances, there's a checks and balances system within our body when it comes to hormones. So what ends up happening is that the luteinizing hormone has to increase to allow the egg to be released, but then it also has to drop off too, in order for the egg to really be fully released. what happens a lot of times in PCOS patients is that the luteinizing hormone increases and then just stays increased and it doesn't drop. So then basically you end up not ovulating. So the luteinizing hormone causes you to have a lot of estrogen and all of the other hormones associated with your period, so that a lot of these patients, they might get the breast tenderness when they feel like they're about to have their period, but then period ako na asya na. So that's like mainly what ends up happening, is that this one hormone predominates so much that it doesn't physically even allow for an egg to release. And in order to achieve like your fertility goals, you have to have your egg release in order to like meet the sperm in order to create life. But when your like ovary isn't allowing you to even release that egg, that's what mainly ends up being a problem.
Exactly. So PCOS, the irregular cycles, as a physician, is the first sign to me that, oh, you're not ovulating. And if you're not ovulating, that's why it's difficult to get pregnant. But that's why, especially for our patients, if you feel like you have these symptoms and you want to start a family, be proactive and see the doctor, because trying without ovulation isn't going to get you pregnant. Getting your cycles under control and treating the underlying syndrome is going to help.
Right.
So, okay, let's say, Dr. Siddiqui, a patient comes in, she's 22, she has irregular cycles, she has the facial hair, and you want to do a workup for her. Like, what are some of the things that you would consider starting to collect?
Right. So for the most part, a 21-year-old in the US that's coming to see me typically is probably not coming to see us for infertility things. She's probably coming to talk about like her periods not being controlled. So the main thing, even before I do that much workup, well, first of all, you kind of gave away some things. Irregular periods already is like flag number one. And you said that, you mentioned the like facial hair. And one thing I actually have found very useful over time, and এটা কিন্তু প্রথম থেকে করতাম না, but like what I found useful over time is directly asking patients, hey, do you ever like shave your like face? And it ends up being a really difficult discussion because no woman wants to admit that, right? However, if you find out from your patient's irregular periods and that she does find herself shaving more than she should, certainly like areas like for women, like the hair and chin areas, those are not typically hair growth dependent areas. So if she tells you, or you somehow find out that she's doing that, that also should be your like that's my second red flag. And I think just her telling me that already gives me the signs. If I really, really wanted to make sure, I can get an ultrasound and tell her, yep, you're exactly what we suspected. But sometimes some of our patients don't have insurance, and an ultrasound can be an extra $50 for her. So if I can save her that money, then just based on what she's telling me, I'd say it sounds like you have like at least symptoms of PCOS, and the best way to treat it, my go-to right away, is to talk about birth control pills.
And also just to keep in the back of your mind that it's not always PCOS, there could be other abnormalities. So typically add on a bunch of labs too to see. The prolactin, but these are less common, but prolactin levels, your hemoglobin A1C, is there any underlying diabetes? So we would just get a bunch of other labs too, just to make sure that those aren't causes. And once you find out they're normal, then we think, okay, it's probably PCOS. Though she's 21, she probably doesn't want to get pregnant at this point. She's not married or whatnot. Though, what's a reasonable treatment for her? Dr. Siddiqui, you just mentioned it.
Yeah, so even though whenever we talk about birth control, we always say that the best option is the IUD, which it really is when it comes to birth control, because it's just locally sitting inside of the uterus, acting both as a barrier and hormone mediator. But in this situation, yes, we're calling it birth control pills, but honestly what it is just hormone containing pills. So yeah, it'll prevent you from getting pregnant, and that's what they are designed to do. However, because they have this extra bit of estrogen that you're taking from the outside, what it's doing is then helping your body's own like hormone production suppress. It sounds and I remember when I was like first learning this in like 9th grade, this whole like checks and balances system, I thought it was like both fascinating and very difficult at the same time to understand. But you would think that bringing estrogen from outside into your body, and you're already telling me that my body has a lot of hormone, that doesn't make any sense. And you're right, it doesn't like intuitively make sense. However, our body has this really like fascinating way of taking anything extra that is being given to us and using it in the form of what we call negative feedback in science. So this extra outside estrogen from this pill is actually going to help your own body's estrogen production go down. So that's like the main way in which like birth control pills that have estrogen. So remember, there are also birth control pills that don't have any estrogen at all. So these are patients who take pills that have both estrogen and progesterone, and that this helps calm the like hormones down. It helps like her get to a point where the hormones are low enough for the egg to be released so that she can have a period. And also the biggest added advantage to taking hormonal birth control pills is that it helps with the like androgen hormones, the hormones that cause for hair growth. Those also come down too.
And just to clarify what Dr. Siddiqui said, it helps you get there. So when you're actually taking the birth control pill, you're not ovulating, and that's how birth control works. But it helps regulate your cycle. So every month you'll have a period. And I sometimes kind of tell patients that, when you're not having a period for 3 months, you're building up all that bloodline and then you're shedding it at once. These women have really heavy cramping periods. But with the period, with the birth control pill, you're having a monthly normal bleed, like just having a cyclical normal bleed, but you're not ovulating. So this is a good option for you if you're not thinking of having a family, but you need to regulate your cycles. And like Dr. Siddiqui says, also helps with the facial hair and the acne. It's also, birth control pills are used for really severe acne too. So acne driven by androgens will help. Our active nature to long-term, PCOS actually is a risk factor for endometrial cancer, which is cancer of the endometrial lining. That's done in the future. But if you take birth control pills and you regulate your monthly cycles, that decreases your risk. That's an additional benefit.
I think one thing I have to often, especially in situations like this, remind my patients is that when they say that they're not like having their period for 3 or 4 months, in their mind, they're thinking that my uterus isn't even generating that blood. Like it's just nothing is happening with my ovaries and uterus. It's actually not true. Things are very, very much still happening in your ovaries and your uterus, but you just don't know it. So these are women who feel bloating, gano, because their uterus is filling up with blood, but it's just not coming out. So that's why when they finally have their period, it's like a period that never, ever ends. So that's why it's important to remember that it's not that your body all of a sudden generates this blood and then you have your period. Things are still happening, but it's building up and building up. And that's exactly what we don't want to happen. But don't think that nothing's happening, because I feel bad. A lot of times I have to clarify that to patients, and they,
But I can see why they would think that, right?
If you don't see it, then it's not happening. I understand that, but still.
Yeah. So another form of birth control is just the progestin-only pill, but your doctor might also prescribe you 10 days of progestin. So you take it, on day 10 you stop it, and then you have what we call a withdrawal bleed, and that's a way of inducing a period, and you do that monthly. So that's an alternative option. If, for example, estrogen is a contraindication for you because you've had a stroke, a blood clot, or you have a history of breast cancer that's responsive to estrogen. Good for you.
Right. And think about what Dr. Hussein just said. It's once you stop taking that pill, that's when you have the period. So imagine if you're not having your period, what's going on in your body? You have a buildup of hormone. That's what's happening.
Exactly. And also just to backtrack, if you're a young woman and you start having irregular cycles and you haven't had a period for 3 to 4 months, first thing you should do is actually do a pregnancy test if you're sexually active, because I have so many patients who have PCOS who are like, oh, I'm a PCOS, that's I'm not going to get pregnant. And they accidentally get pregnant because they have no idea when they're ovulating.
Yeah.
And then they're pregnant for 3 to 4 months without even knowing about it. So always do a pregnancy test.
Yeah.
You never know. You just need one ovulation and one instant and boom, you can have a baby.
Absolutely. And that's a really, really big point, though. Even though a lot of times the patients that we see in our practice who come in with these like issues end up being because they can't get pregnant, there are many women out there who just decided, you know what, because of my PCOS, like, I don't think I can ever really get pregnant. So I'm going to just, I don't want to say reckless. That's not the right term. What I mean to say is that they just don't, because they believe that they can't get pregnant ever. They never time like their intercourse. They don't look at their period as like the vital sign, and then they end up getting pregnant at a time that they didn't think that they ever could. Or worse, they end up being pregnant and not realizing it until they're like in the second trimester, because the first trimester is what, 13 weeks. 13 weeks is 3 months. If you don't have your period for 3 months and you have PCOS, you're thinking, I have PCOS, that's all. Yeah. I actually had this one patient who had PCOS, and same things. Like, she never thought that, oh, imnite, like, just to get pregnant with my other 3 kids, I had to take so many, like, I had to basically do IVF in order to like conceive with them. But then at age 51, she conceived completely naturally.
Wow.
And I mean, it happens because she's got PCOS, hasn't hit menopause yet, randomly ovulated at some point, and then got pregnant.
Exactly. Like, statistically much lower, like
Much lower.
12 ovulation events every year. PCOS
Yeah.
probably fewer, but you never know, it can still happen. So.
Right. It doesn't mean that you can't get pregnant. So you definitely, for better or for worse, you definitely can get pregnant.
Yes, yes. But, there are ways to help. And so for our PCOS patients, and this is probably most of you actually who are interested in PCOS who want to get pregnant. First of all, as a woman, you need to know that this is not your fault. You are not any less worthy or insufficient to your partner, to your family, because it's difficult for you to get pregnant. So a lot of these women harbor guilt. They think they started this. This is their fault. How could I not be a mother? What's wrong with me? No, absolutely not. We are genetically prone to this. There is a lifestyle now that is very diabetogenic. We're all going to have diabetes earlier because our diet is so terrible now in the United States, and I'm sure in other parts of the world. So take the blame off. And then second of all, acknowledge your diagnosis. Know that there are certain aspects that you can control and there are certain aspects you cannot, and then work with your doctor. I think a lot of these patients are very sensitive because weight ends up being a topic of discussion. Yeah. So I see the weight actually as a good thing because it's something we can control, to a certain extent, do something about. Whereas if it's something genetic and underlying, I can't go in and change your genes, but the weight aspect we can work on. So like we talked about before, even as little as 5 to 10% weight loss can result in the regulation of cycles, which basically means that your ovulation has returned. So that's our first line treatment to weight loss. So looking at your diet, talking with a nutritionist, exercising 5 times a week, and really focusing on weight loss.
I have a question, Dr. Zain. Do you start with that right away? Because I feel that for the most part, I've had to I do the weight loss and like counseling for all of that. That's obviously paramount, behavioral changes, but I also start them on birth control pills too. Kind of.
If you want to get pregnant though, I can't really do that yet.
Yeah, I guess what I end up doing is I still give them a trial of birth control pills just to achieve regulation of the period. As long as we can get to a point where like, okay, have we regulated it? Okay, now are we at a point where we can, in a way, predict your ovulation? Great. Take the birth control pills out of the picture. Yeah. That's the way I think about it. But you're totally right. A lot of these patients, they don't even want that trial because they are trying to get pregnant at a later time in their life. They kind of want things to happen sooner. So yeah, you're right.
Yeah, no, it's a combination. It's very much case by case too. So, if someone is borderline, maybe the weight loss isn't going to do much, but someone is a pretty significant or room for weight loss. I think a little bit of weight loss is good, not only because it'll result in, like you said, resumption of menstrual cycles, but you will have a much healthier pregnancy. If you do get pregnant, obesity in pregnancy is extremely high risk. There are a lot of associated risk factors: preterm labor, IUGR, and growth restrictions, stillbirth, diabetes, preeclampsia. Though we always want to reduce that. I thought for long-term life benefits of reducing risk of diabetes and cardiovascular disease, which is known to be a known downstream association with PCOS.
Do you also, when you do your workup for patients like who have PCOS and in order to do their fertility workup, even though clearly it looks like this is a female factor issue, I always also say do the male factor workup too, because I feel bad. A lot of our, like, especially our Bangladeshi patients, when somebody tells them they have PCOS, they think their infertility is just their PCOS, it's all their fault. And it's a lot of times patients who come in for infertility issues, it can be a mix of things. Like, it can be a PCOS issue on the woman's end. It could also be purely a male factor issue too. And both of them coming together is making things worse. So I think that's always really important, because I think women are so conditioned to thinking that, like, in a way, biologically damardosh. So that's why I have to get all of the like lab work and the treatment, and then there's no even conversation about the fact that it could be also a male issue too. So I always say, if we're going to do the workup, we're going to do it well with everything.
Exactly. I definitely agree. When we're working up infertility and not irregular menses, Stockholm, we would have to do a more comprehensive workup, which is male working up the partner, and then doing an ultrasound, seeing if there are any polyps, structural abnormalities of the uterus, structural abnormalities with the tube. So definitely, yeah. We're discussing that given that workup, everything shows PCOS as the main cause, and these are the sort of things we'll do. So when, let's say you have a patient who's tried, lost some weight, is getting cycles again, but still having a hard time, other things we can do is, what does that mean? They're probably, even though they're having regular cycles, they're not ovulating. So your doctor might give you a medication called letrozole, which is an ovulation inducing medication. So there's another one, Clomid, Dr. Siddiqui. Do you want to talk a little bit about it? Do you want me to talk about it? Whichever.
Oh, no. So Clomid, actually, I think, is probably the one that's cheaper and is more available in Bangladesh. Clomid, like, full name is called clomiphene, and your doctor might have talked to you about that. That's the one, even though the first medication that Dr. Hussein mentioned, which is letrozole, we use that more in the US now. But Clomid, actually, some generalists prescribe Clomid too in the US, but Clomid is the one that I think is more readily available. So what it does is it allows you to actually ovulate. One of the side effects is that at times when you ovulate, instead of releasing the one egg, you can release like more than one, like two. So a lot of times women who try to get pregnant by taking this medication first in order to allow their egg to allow their ovary to actually ovulate and release an egg, they end up getting pregnant with twins because their ovary ended up releasing two eggs. So that's one concern, and that's something that you just, like, that's a risk that you take on. But like Dr. Hussein was saying, it is designed to help you ovulate so that, like, an egg is actually released.
Yeah, and your doctor will go through, there are very specific instructions in how you take it, and sometimes some doctors will do ultrasounds to see if you're ovulating, and then you will have to time your intercourse to get pregnant. Recent studies from the American College of Obstetricians and Gynecologists say if you have a choice between letrozole and Clomid, we prefer letrozole. Letrozole has been shown to be more effective in PCOS patients. So if you have that option, definitely talk about that with your doctor.
If you somehow are getting these medications like online, we definitely don't want to send home the message that this is a medication that'll make you get pregnant.
Correct.
Definitely, if you are some way acquiring these medications outside of your doctor, please, 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 at least inform your doctor, because it's so important. It's not just you taking this medication and you getting pregnant. It's this medication, how it affects your body, and us having to do an ultrasound to see if you are a good candidate for this medication to begin with, and following you. So that's really important, because I find so many of my patients who in the past who've had infertility issues, unfortunately, they get desperate and they find medications that we're talking about on the line by some off-brand provider, but they don't end up taking it with the counsel of their physician. So I think that's
because it's not just taking the medication daily. It's very scheduled. You're supposed to take, there's a recommended starting dose, then you go up, and you're supposed to take that on certain days. So absolutely don't harm yourself by taking it off the street or off.
Yeah, and any medication can really be found off the street. So that's why this is one of the.
In Bangladesh, I hear you can get any medication you want from the pharmacy.
Yeah.
So I caution all our patients of Bangladesh, please do not do that. You will endanger yourself. So do not do that. You do that. talk to your doctor to do that. Good thing you brought up, Dr. Siddiqui. So let's say we've had a patient now, she's tried multiple cycles of letrozole, you tried some Clomid as well, she's tried weight loss, still not getting pregnant. Sometimes this is not common. I don't know if you've seen this, Dr. Siddiqui, but some places you can do a procedure called ovarian drilling. This is what at this point, you will probably not be seeing someone like me who's a generalist. You will be seeing an IVF specialist. The ovarian drilling is when they actually do the gynecologists do laparoscopic surgery and actually put little holes on the surface of the ovarian cortex. And that has been shown to help with ovulation.
Yeah.
But I haven't seen that too often, but I've heard about this as a potential.
I think sometimes our infertility doctors do it, but even in the infertility literature, this is not like a go-to. It's sort of, it's almost like I've done it one time, but that was because we were already doing a procedure for another indication and we used the advantage of that. But it's very risky. I mean, it's still surgery anyways, so it's very risky to do that just for something like this. So.
And so that leads us to, if none of those treatment modalities work, your best bet's going to be IVF, which is seeing an REI, infertility specialist, who will mix your egg and your partner's sperm separately and implant.
Yeah, it's like only many Bangladeshi call it test tube baby, but it's not like literally that. So it's just like the contents come together in a test tube, but then you take that and actually implant it in the uterus. But they call it.
But no, actually the baby comes out of a test tube, like straight crawls out of a test tube.
Exactly what they say. I'm like, that's not what's happening. Maybe that's the future. I think that's the future, that eventually this baby will grow in a test tube.
Yeah, exactly. We can only hope one day, right?
Yeah.
So I think that's like the main important thing, is if infertility is part of your like sequelae of PCOS, you got to be proactive about it. Just waiting years on it isn't going to help, because we have, the first line of treatment is weight loss, which is going to take some time. So be proactive. The moment you notice that your cycles aren't regular, you have to talk to your doctor about this, because it's a very important diagnosis, and see it as a blessing. This is your body showing you, hey, I'm not healthy. I'm not doing well. Yeah, I'm going to suffer from diabetes and cardiovascular issues down the line. We need to get on top of it. So men don't have that. Men don't have a monthly period to look at. So as women, we get that insight. So take advantage of it. Don't take it lightly. Yeah.
Not having your period, I think, for so many women is like a cause to celebrate, which it is. I understand that completely. But like missing it, like this is why we always keep saying it's a vital sign. If you miss your period any month, there has to be a reason. Whatever that is, there has to be a reason. You have to figure that out.
And another thing to mention, just, this is not always done, but metformin, which is a medication I'm sure a lot of us diabetic patients take, can also be sometimes used to help with the insulin resistance component of PCOS. So if your doctor starts you with metformin, don't be alarmed. That's probably one of the multimodal treatments for PCOS.
দেশে কিন্তু এটা like প্রায় সময় করে. A lot of the doctors actually prescribe metformin right away, which is, I mean, metformin doesn't have too many crazy side effects. It can be expensive, which is okay.
Yeah, you could have some GI discomfort.
Yeah, which is, it's not my favorite medicine to go to, but I actually do see that in Bangladesh a lot. They like kind of prescribe metformin and say weight loss, but they don't talk about birth control pills. They do that like later, which is, I think it's probably because it's easier to prescribe a woman metformin than it is to prescribe birth control pills, because
there's the stigma.
There's a stigma.
We always know that most of the time birth control medications are used for non-contraception reasons. So
it's just extra hormone, right? Yeah. So I feel bad though, because a lot of times these patients come out taking metformin, even though they're not even pre-diabetic, and they think that that's the medication that'll help with their PCOS. It won't help with their PCOS. It'll help with their risk of developing diabetes, but that's different. So just be careful. Whatever medications you end up getting prescribed by your doctor, just like really read about it and try to understand it, because you should know what taking and
What
why.
you're taking. Exactly. And these medications, metformin is safe. If you were to get pregnant, it's not, not a bad thing. Another thing is if you're trying to get pregnant, always start taking prenatal vitamins. Just start it away. A lot of people don't realize that. Just start that. We hope that you benefited from this session. There's a lot of mystery surrounding PCOS. So this is just getting that conversation started. So if you have any questions, always, general questions that you didn't feel like we addressed, just pop us a message and we'll try our best to address it next time. We're looking forward to hoping that you guys benefit from this.
Let us know your thoughts and feelings and questions.
Yes. Well, what are you going to do for the rest of the day, Dr. Siddiqui? It's just Sunday, right?
Yeah, it is a Sunday. Yeah, it's a Sunday where you are too.
Exactly.
Oh no, I'm going to make some dal.
Oh, did you do it last time?
Yes, I did last time. But I get a lot of anxiety about the dal to pani ratio, so I'm just trying to achieve that. Are the things that perpetuate my anxiety, like dal to pani ratio.
Important, yeah. Bishi
khana or bishi light, yeah.
Yeah, nothing like good dal, though. I think.
Yes, that would be my if I was. I don't know why I just thought of this, but if anyone ever put me in prison and said, what would you like for your last meal? I would eat dal bhat with my hands.
Exactly. With the hands. Exactly.
With the hands. It's the best. Otherwise, it doesn't taste good.
Does not taste good. Exactly. Oh man. Well, good luck with that Sunday picture.
Yeah.
And to everyone at Herwell, thanks for joining. We're so happy that you joined our talk today. Take care.
Thank you so much. Have a lovely weekend, everyone. Bye.